Hello, welcome. My name is Dr. Eliana Ramirez. I am the director of the CARE TA Center. We are the Crisis and Recovery Enhancement Training and Technical Assistance Center for the state of California. We are funded through Mental Health Services Act to provide training and technical assistance to the MHSA funded counties' behavioral health programs across the state of California. I am thrilled to be here today with Dr. Wayne Lindstrom, who is joining us from our partner agency, RI International. Today is the second in a 3 series of Cafecitos discussing the Crisis Now model. And for folks who are just joining us for the first time, I want to give you just a brief background of what the Cafecitos are, and then I will invite Wayne to join the conversation as well. When the pandemic started, many of us sheltered in place, and we noticed a missing of interaction with our colleagues. No longer do we have the opportunity to run into each other in the, around the proverbial water cooler or in the staff lounge area, or to chat with one another from our cubicles. And so we found that these cafecitos are informal conversations among colleagues that many of us are missing, not only for the social aspect of our work, but also because these informal conversations can oftentimes lead to important changes in our work. And so we are so lucky to have Wayne here talking to us again about the Crisis Now model. Welcome, Wayne.
Thank you very much.
So last time that we chatted, you talked about the Crisis Now model having 3 major components. I wonder if you would share a little bit about those 3 components, please.
Yes, I'd like to refer anyone who happens to be tuning in to go to crisisnow.org, which will provide them with more detailed information. That web portal is hosted by the National Association of Mental Health Program Directors, state mental health program directors, and I'm the former president of that organization. So that's a great resource. And for an even better drill down, if you will, I'd like to refer everybody to the National Behavioral Health Crisis Care Guidelines that SAMHSA basically published last year, which is a great guide relative to the Crisis Now model and the principles behind it. And it's kind of everything you ever wanted to know about behavioral health crisis care. So with that, the Crisis Now model focuses, as you said, on 3 core components. The first is what we now call the Care Traffic Control Hub. That is, in essence, a metaphor from the airline industry, air traffic control. And we know that when you're talking about managing aircraft in flight, that safety is number one. It's been estimated that if we had a 1% error rate, we'd have something like 350 crashes per day, which would not be acceptable to any of us, and we would not fly if that were the case. But when it comes to the corollary, if you will, of folks in behavioral health crisis, we've never had a system that assures that from the point of someone emerging into crisis that they ever get a safe landing. If anything, we've been willing to accept a system that probably in many respects is set up to assure a crash than we are a person ending up in a good place that better positions them for initiating a course of recovery and a higher quality of life. So if you think about, how reliant we've been on 911, where police are typically dispatched, and you get individuals in uniform and they're armed and they're in police cars and sirens are wailing, etc. If you've got somebody who's highly anxious or agitated, etc., it's not a calming introduction, if you will. If anything, it tends to exacerbate symptoms, particularly for a population that oftentimes already has a trauma history. And so it leads to, poor outcomes, and we've seen too much evidence of that in communities across the country. Care traffic control center hub in our parlance is really a technology-enabled call center within which there is GPS technology so that the call center knows the locality from which the call has originated. They also use that technology with knowing where their mobile crisis teams are, which ones are available, and they can dispatch the team that's available and the closest to the person in crisis to intervene on the street, under a bridge, in somebody's home, in a person's natural environment, so to speak. So when we're doing this well, we would expect that 90% of the folks who access the crisis call center, they can be stabilized at that level and not necessarily need a mobile crisis team dispatch, for example. And when mobile crisis teams are dispatched, roughly 70% of those cases can have an appropriate level of stabilization as well. And that leaves the remaining 30% of folks who need to be referred to a higher level of care, which would be a facility-based crisis service, which basically has two components associated with it. The first is what we call a crisis response or receiving center that's available 24/7. It does not have beds. It has recliners. And the reason we use recliners is that as an alternative to beds, because when you use beds, they're highly regulated in every state. And once those beds are full, they're full. You can't admit the 17th person. And once you start saying no, particularly because we design these services to be very dependent on drop-offs from the back of a police car, when you start saying no, then the police stop utilizing your facility. So by virtue of using recliners, we can basically always have the front door open. And then on the back end is another facility with actual beds. And because of the IMD exclusion, unless there's been a Medicaid waiver that has been gained from CMS, has to be limited to 16 beds. Something like 30% of the folks who've been in the crisis receiving center need longer term stabilization. Our average length of stay in the crisis receiving center is 7 to 10 hours. And in the crisis stabilization center with beds, folks can stay up to 2 weeks if necessary. That oftentimes is not necessary. And so those are in essence the three main components: the crisis call center, the mobile crisis teams, and the facility-based crisis services. Now, that's not the entire continuum of crisis care or behavioral health care that a community should have, but those are the three key components of Crisis Now.
It's so exciting always to be in conversation with you about this, Wayne. I think in addition to the ways that you provide kind of a framework to thinking about crisis care, you also present the information in a way that is really person-centered, that starts from the perspective of the person who's experiencing the crisis. And so when you started to talk about the experience of police arriving when someone calls 911 because there is a mental health crisis, let's say maybe a family member is experiencing a suicidal crisis. And when you talked about the police arriving with the sirens and weapons, which of course police need to have because there are times when they need to use such things, but in the moment of crisis, it can really escalate the situation. That was a really powerful way to think about what it means, because I think for many of us as licensed clinicians, we become automatic in calling 911. And it is something that we do because we're thinking about safety issues. But what I've heard you say is actually that the ability for the client or the person who's in crisis to be calm and to down regulate, that's an issue of safety as well. Um, and I appreciate that you were talking about the recliner chairs as an option, that only 7 to 10 hours is how much time people need oftentimes in these environments. You were sharing earlier about the idea of a ladder and the rungs. I wonder if you might share that a little bit about that metaphor as well, please.
Sure, I would be happy to. Um, the the piece that I wanted to share based on listening to you just a moment ago, before I get to talking about the ladder, so to speak, is the fact that the real key to being able to do a facility-based crisis stabilization in a 7 to 10 hour framework is about meaningful engagement. If you go in a lot of places that call themselves, a crisis center, oftentimes you'll find the staff behind plexiglass. You'll find folks, lounging around, maybe sleeping. They're isolated, maybe a TV is on. And then we wonder why folks ruminate, they feel isolated and alone, maybe become more agitated because they feel like they're just being warehoused there. And there's an underlying message there of disrespect. So we have an expression in RI International that, peers first and peers last. So the person with lived experience, and roughly 50% of our personnel in all these facility-based crisis centers are peers, people with lived experience. So when that person comes into our sally port from the back of a police car in shackles, we never say no. It doesn't matter if that person is actively suicidal, actively psychotic, under the influence of a variety of substances, etc. We accept everybody. And the first person who engages at that point is somebody with lived experience who might be able to say, I know this has been pretty awful for you, because 3 years ago, I went through this myself. We're going to have the police out of here in 3 to 5 minutes. And, we're going to make you feel at home. If it's appropriate, get you cleaned up. If you're hungry, get you a meal, etc. And then throughout those 7 to 10 hours on average that they're with us, there's peers engaging them most of that time. Now, if somebody is really at a place where they can't tolerate overstimulation, then we have safety rooms. So if somebody, is overstimulated, needs a calming place, etc., we can use that too. And they can be there for a time by themselves, or a peer can be engaging them in that environment as well. So the secret ingredient to the secret sauce really is this piece about meaningful peer engagement. So I wanted to stress that. In talking about the latter, I was referencing that what has been wrong with our system for far too long is that we had basically at the lower end of the ladder outpatient services, and then at the other end, we had inpatient services with little in between. And so if somebody was actively psychotic on the street, they get picked up by the police and they'd be taken to an emergency department for evaluation and then probably admitted to an inpatient unit. Upon discharge, there would be very few alternatives, so they'd get referred to traditional outpatient, which oftentimes, has a waiting list in a lot of communities. If it requires an appointment with a psychiatrist, or a psychiatric nurse practitioner, that might be 3, 4, 6 weeks out. And there, the continuity of care really isn't there. The person is discharged. They don't remain stable given that they haven't had really a service that's tailored to what their needs actually were. So they decompensate or whatever the case may be, ruminates, become suicidal again. Then they end up back in inpatient. We've had this revolving door over and over again. Communities get frustrated, the police, the sheriffs, the emergency departments, because they see the same people over and over again. And so the crisis now model, in large measure, is about breaking that cycle and building the other rungs of the ladder so that there is an appropriate crisis care continuum and post-crisis care continuum as well. And much of that, so the services that we need in most communities are community-based intensive levels of service. So if we're talking about kids, this are things like functional family therapy, multi-systemic therapy. It's intensive, it's in the home. It's not a center-based, kind of service. For adults, it can be, assertive community treatment teams or PAC teams or FAC teams and intensive outpatient programs and partial hospitalization programs, et cetera. So we have a lot of work ahead of us in building those intermittent tiers.
Again, with the person-centered perspective, when you talk about somebody who's in crisis being welcomed into an environment and first and foremost checked in with what can we do right now to help you, to calm and to get into a place where we can start to engage in some support that would really make a difference. It's talking about, are you hungry? Can I get you something to eat? Do you need to be somewhere quiet for a little bit? These basic needs that's such a trauma-informed way to engage people. Because if we're hungry, how are we able to focus on having a conversation and problem solving challenges, or just to even calm down? That there's a way in which our autonomic nervous system is in crisis mode, and it's going to continue being in crisis mode until we help our system to actually calm down. I really appreciate you talking about that, and about this idea of intensive treatment in the community and in people's homes, and that we stay outside of facilities as much as is possible. I think that's not just a matter of practicality. I'm imagining some of our audience members who might be from rural areas or places where they have fewer resources, but also in terms of how different people need different things. Children need something different than adults per se, in terms of helping them to be calm and to engage in their own recovery. I wonder if you might talk a little bit about this idea of access to services if you're in a rural area as compared to in a more of a city area where there are more resources typically.
Yes, but I'm going to have a brief intersection again,
Okay.
if you will. I think that if I were to frame this theoretically, it's not new to anybody who may be participating, and it's really this transition from the traditional medical model to a recovery and resiliency model. And so the medical model historically has been the professional in the white lab coat who has the answers. You're coming, you're going to get diagnosed, you're going to get treated, we're going to do something to you, and we're going to make you better. And that the onus is on us. And as a result of that, when we talk about facility-based crisis services, the tendency has been, well, we can't possibly admit somebody without having clear admission and exclusionary criteria. And oftentimes those criteria have been the barriers to be able to even accept somebody into a crisis facility. So how many crisis facilities have you known that saying we cannot admit you unless you have a medical clearance? Well, a medical clearance means you're going to the ED to get that clearance, which oftentimes can be an experience that involves, long times for onboarding, because if you're going to an ED and you're not bleeding or whatever, you go to the back of the line in the triage process. If you are acting out and you've been in police custody, the police are going to remain there with you. If you aren't orderly and conducting yourself in a way that isn't disruptive to the folks in the emergency department, you're going to end up in seclusion and restraints, which again is another trauma. So we want to avoid all of that. So we don't want to find reasons not to take you into our facilities. We're going to say yes 100% of the time, and we will have the medical personnel that are required to do our own medical clearance. And if it turns out that the person, has a heart arrhythmia, or their sugar is so out of whack, et cetera, with diabetes, we will then arrange for the transfer to the emergency department. And when we get the medical condition stabilized, we will manage getting that person back to us to continue what brought the person in the first place. So I just wanted to emphasize that point with you. And in the interim of belaboring all that, I forgot what you asked me.
I'm not entirely sure either way. I enjoyed chatting with you so much that but what you were just sharing reminds me of
rural.
I'm sorry?
It was about rural.
Oh, yes. Okay. Well, before we go there, if you would hold on to that for just 1 second,
All right.
because this is reminding me of the National Behavioral Health Guidelines that you mentioned that SAMHSA published and that I know RI International was involved in co-authoring. And for folks who haven't read it yet, I cannot speak highly enough about this document. And I'm not just saying that to fluff the feathers of Wayne because his RI was involved in it, but really, truly, I think it is one of these really seminal pieces of work that does such a lovely job, not only bringing us all onto the same page with existing work, but really summarizing in a way that I think is immediately applicable to the work that we're doing. And one example of this is the idea, and you talked about this a little bit, if we are to create a culture shift where officers are going to take the time to drive someone to a facility like you're mentioning, a brief stabilization facility, as opposed to an ER, as opposed to a jail, that part of the decisional factor there is going to be about whether or not they're going to be able to get in and get out for the next call that they're going to receive on 911. And if they know that everyone will be accepted, as you mentioned, that there's no exclusionary criteria, but also that there is a system in place for those officers to get in and out of the door very quickly, that's going to make a difference. And I really appreciate how RI International talks about this piece of, historically, we've oftentimes encouraged our mental health staff to think from, or we've encouraged our mental health staff to consider that we need our officers to think like a mental health clinician. But in fact, I think what you're repeatedly encouraging us is to encourage us to think, what are the experiences of our officers who are being called in as de facto mobile crisis unit providers or mental health crisis counselors? In fact, that's not what they're trained to do necessarily. And it's not what the system is set up to do, even if we have officers who are interested in participating in that way. I wonder if you might talk a little bit more about these specifics of how our brief units might support officers to kind of get in and out, get out quickly. I know you've talked a little bit about this with emergency room departments, but if there's anything else you might kind of put out there into the community that might whet the appetites of folks who do this kind of work.
Well, actually, I would advocate that we not spend so much time on that topic because of the implementation of 988. We touched on that on our last Cafecito in talking about mobile crisis teams. the reality is that the FCC last summer designated 988 as the alternative for behavioral health, as analogous to 911. Congress passed a major piece of legislation following that in October, authorizing all the states to implement 988. All the phone carriers are required to technologically implement 988, and the states were given the authority to exercise a phone surcharge fee, not unlike they do on the 911 system that largely funds 911 systems across the country at the state level. So we have the opportunity, because this goes into effect July of 2022. That's less than a year and a half away for us to have 988 implemented. And each of the states have received planning grants from Vibrant, which is the entity behind the National Suicide Prevention Line, the Lifeline, to begin planning and get those submitted by this summer, so that there can be appropriate legislation. And from the last I learned, I think 16 states, including California, have introduced the necessary legislation as we speak. So to spend a lot of time now about how do we get the police to maximize the utility of the Crisis Now model, that in essence is in the process of being eclipsed by this larger national initiative, if you will, around the implementation of 988, with the goal that we will, for the first time in this country, have a behavioral health crisis response system that is on par with the 911 emergency medical response system. And so Crisis Now will be folded into this other larger restructuring, if you will.
Wayne, you're the bearer of good news again and again and again. It's so exciting to have that elevated again. So thank you for bringing that up. And that takes us really nicely over back to our conversation then about rural communities and how we might think about crisis in rural, if you would, please.
Well, if you think of that Chinese adage about in crisis, there's opportunity. The same, I think, is true of the COVID-19 crisis that we've all been living through, this pandemic, which overlaid with a lot of other things, I've often described as dystopian, this phenomenon, that we've collectively experienced. And fortunately, it looks like, we're finding our way out of this. But in the interim, providers across this country either had to switch to telehealth or telepsychiatry or telepsych, whatever you want to call it, in a much faster trajectory than any of us had imagined. And as a result of that, if you were going to stay in business and be able to serve your clients, in many places, that was the only way you were going to be able to do it, particularly for outpatient services. So now we've developed this competency, if you will, adopted the technology necessary to do it. Staff, were trained, and it's becoming part of, the clinical repertoire, if you will. And this really gives a leg up in delivering care to rural communities. And things like Project Echo, which we could do another whole thing on, which originated here. I'm in Santa Fe at the University of New Mexico, but now it's gone global as a way to provide specialty care in rural and frontier environments. So if we talk about the Crisis Now model and talk about, one component, mobile crisis teams and or facilities, you're not going to be able to have mobile crisis teams in every rural community in America, just like you're not going to be able to have crisis centers. They're going to have to be organized where there's the population density to support them. But it might mean using somebody in the community. It could even potentially be a peer. You might use a tablet and have a clinician who remotely is there doing the crisis intervention along with the peer who's actually, on the spot. And it might mean that mobile crisis teams look very different as well. You might, because the crisis facilities would be scaled back in rural areas, not have the same capacity in more densely populated areas. And so you have staff that do double duty. They're not always assigned to a mobile crisis team, but given that those calls for a mobile crisis team might be much less in terms of, frequency, they can in essence be on call and get dispatched. And then you have ways to compensate for the staffing in the crisis center, et cetera. So there are ways now, I think we have the tools, and there's more and more emphasis, and there's a lot of money in the new rescue plan the Congress just passed around COVID that's about building out broadband, because in a lot of states and rural frontier areas, that's still a major challenge. So those barriers are going to be increasingly overcome as well.
What a powerful and beautiful and hope-filled way to start this off, to talk about the opportunities that are part of crises. And I really appreciate you centering also the experience of rural communities and this real strength that the adaptations and the creative problem solving that rural communities have been engaged in are really leadership models for the rest of us right now in a world where we are having to be social distance and being forced into a teletherapy kind of environment. I think that's a really nice flipping of the script, as some people would say. And it's a way, I think, that's also really important right now, as more and more people are also moving to more rural areas and away from the city centers with the pandemic. That's also another kind of trend that we've been seeing in several areas, certainly with veteran populations as well.
Well, the biggest challenge, if I might interrupt, Eliana, is the lack of a behavioral health workforce. And, it's really difficult to attract psychiatrists and psychologists and social workers and psychiatric nurses, et cetera, to these rural communities. But what we found, I know in New Mexico, we've had for about 15 years plus a rural psychiatric residency program through the medical school at UNM and Department of Psychiatry. So they do a clinical residency in rural communities. And we've found over time that 60% of the folks who do their residency training in a local community will stay in that community, even though they originally were not from that. Likewise, WICHE, the Western Interstate Commission on Higher Education, has a psychology internship program that's been implemented in a number of states, started with Alaska and I think Hawaii. We've done it now in New Mexico. Same thing, psychologists who do their internships in a rural community, 60% will stay upon completion. So these are some more homegrown ways, if you will, to attract professionals in these rural communities. And if you take a state like Nebraska, for example, 50% of their counties do not have a single behavioral health clinician of any discipline. So we're going to have to deal with, in a much more comprehensive way, the challenges associated with not having capacity with regards to our behavioral health workforce.
It is so fun to have you in these cafecitos, not just because you are an incredible wealth of knowledge, but also these conversations will end up going in a number of directions that I couldn't have possibly imagined in the first place. I was going to say, end our cafecito here by inviting folks to come to our third cafecito, but I have a feeling I'm going to be inviting you to a couple more than that. You mentioned the ECHO model. I think that there are a number of folks who would be really interested to learn about that as well. So at this point, I just want to say thank you so much, Wayne. While I can talk to you forever, I did promise our audience that we would keep this on the shorter side. So I would ask, do you have any final comments that you'd like to share from a facility perspective within the Crisis Now model?
It's hard to wrap anything up in terms of final comments with regards to facilities. I mean, there's so much that we could talk about in terms of, how many you need in a given locality, where they should be located, how they should be staffed, the kinds of system alignment you need in terms of state licensure standards and Medicaid provider types and rates and coding, and safety net funding for those who are uninsured. Parity we need with commercial insurance because they don't pay for crisis care. Medicare doesn't pay for crisis care, etc. So I would just bring up more topics and more issues rather than necessarily any grounding farewell remarks beyond that.
It's so fun to chat with you, Wayne. So I clearly cannot stump the judge and by throwing in a left hook at the end there. So without further ado, I would just invite folks to go to the RA International website to learn more, to the Crisis Now website that you mentioned. We will put the link below this interview. And then also to the Care TA Center. We have a series of 3 trainings that RA International are doing for our audience, all focused on mobile crisis units, but perhaps I might be able to invite you all to come back and think about some additional topics as well, related to facilities and the ECHO model. So without further ado, thank you, Wayne, so much for your time, and we will look forward to seeing you again for our third Cafecito interview in the coming weeks.